and director at University of Colorado School of Medicine in Colorado. He's also director of the Clinical Neuromuscular Pathology Fellowship there and has a deep interest in LGMDs. Next is Dr. Eric Posgay. He is an associate director of R&D for LGMD gene therapy at Sarepta Therapeutics, located here in Columbus, Ohio. And I'll be closing out the symposium to discuss our clinical program in LGMD2E. Here's the overall agenda for the presentation. First, Dr. Wicklund will start on the LGMDs and the importance of diagnosis, and that will come full circle at the end as I discuss our clinical programs. Eric will discuss our preclinical development for gene therapy for the LGMDs, and that will transition into my presentation on the clinical development for our program 9003, or beta-sarcoglycanopathy. And then we'll close with a question and answer session. And so with that, I'd like to turn it over to Dr. Matt Wicklund.
Thank you, Louise. And to all, it's a pleasure to have an opportunity to speak to you. The limb-girdle muscular dystrophies are a group of disorders that have proximally predominant weakness in the hip and shoulder girdles. They occur in both males and females, and the minimum prevalence is somewhere in that 1 to 10 per 100,000. This makes it the fourth most common of the muscular dystrophies, just behind the dystrophinopathies, FSHD, and the myotonic dystrophies. There are more than 34 variants that have been determined to be a cause of the limb-girdle muscular dystrophies. And what's important is that you have to remember that each of these have their own unique manifestations, but they have a common sort of phenotype of proximally predominant weakness in the hip girdle and then the shoulder girdle. Limb-girdle dystrophies are autosomal dominantly or autosomal recessively inherited, and the autosomal recessive disorders make up the predominant portion of the limb-girdle muscular dystrophies. There are more genetic subtypes. They tend to have a younger age of onset. The weakness is more severe, and the CK levels tend to be higher in the recessively inherited limb-girdle muscular dystrophies. There is considerable variability in the limb-girdle muscular dystrophies in terms of age of onset, severity, rate of progression, and in general, the disease does start in the hip girdles, and patients will present to you with trouble ascending stairs, arising from chairs, getting up from the floor, and they may have that waddling or Trendelenburg gait. And eventually, when the shoulder girdle becomes affected, they'll have difficulty with using their arms over their heads. And importantly, there can be cardiac, respiratory, spine, such as scoliosis, and cognitive impairment, and cognitive is relatively uncommon. On this slide, this shows you that there are proteins anywhere in and around a muscle fiber, and they can cause a limb girdle phenotype. On the bottom right, you'll see that internuclear envelope proteins can lead to a limb girdle muscular dystrophy. To the left of that, sarcomeric proteins can be involved. In the middle, you'll see sarcolemmal proteins can be involved in sarcolemmal repair or in structure and function across the membrane. Extracellular proteins can be involved with glycosylation of alpha-dystroglycan, and the extracellular matrix can also be involved with the collagen 6 disorders. The limb-girdle muscular dystrophies previously had a nomenclature where the autosomal dominant disorders were called LGMD1, and then there was a letter that followed that was the order in which that limb-girdle muscular dystrophy's chromosomal locus was delineated, and the recessives were called LGMD2, and then there was a letter that was put down as, again, the order in which the chromosomal locus was delineated. We had a problem in that we eventually ran out of the alphabet, and there were more than 26 of the autosomal recessive limb-girdle dystrophies. So our colleagues in Europe in 2017 suggested a nomenclature in which now the limb-girdle dystrophies can be called LGMD D for dominant, and then a number is put down for the order in which the gene was delineated, and LGMD R for recessive, and again, the order in which the gene was delineated. And in this nomenclature, we will not run out of numbers, no matter how many limb-girdle dystrophies we come up with. In 2013 to 2015, the MDA and Jane Foundation sponsored a genetic testing program through Emory Genetics Lab, and more than 4,500 patients who had a limb-girdle phenotype were tested. And those results came out on the left here, where roughly a quarter of the patients received a definitive diagnosis. And this allowed us to understand the relative prevalence of the limb-girdle muscular dystrophies in the United States. And from the left in that graph, you'll see that calpainopathies are the most common. Dysferlinopathies are next. And then the collagen 6 disorders, sarcoglycans, anoctamin 5, and FKRP for Fukutin-related protein. In terms of diagnosing the limb-girdle muscular dystrophies, if somebody has proximal weakness, occasionally distal weakness, such as in the dysferlinopathies and anoctaminopathies, an elevated CK, or a muscular dystrophy that's not X-linked, you should think of a limb-girdle muscular dystrophy. In terms of diagnosis, nowadays we move fairly rapidly to genetic testing, and that provides us a definitive diagnosis if we get pathogenic variants. Sometimes we will need to circle around for variants of undetermined significance and do either biochemical testing or perhaps a muscle biopsy to further clarify some of these variants of undetermined significance. The diagnostic process truly has changed for the limb-girdle dystrophies, and now broad genetic testing should be performed once a clinical suspicion is present for a genetic muscle disease. Let's take a little sidestep and talk about genetics, and especially the terminology for genetics. In the past, we talked about mutations and polymorphisms, and mutations mean a permanent change in the nucleotide sequence, whereas a polymorphism is any nucleotide sequence change with a frequency above 1%. The challenge is we always assume mutations were pathogenic and that polymorphisms were benign, but that's not the case. And so nowadays, when we talk about the genetics, we talk about variants. And these variants can be classified as one of 5 types. They can be pathogenic, they can be likely pathogenic, and likely pathogenic tends to come when there is a change in the genetic code in which there is perhaps a protein that is either a truncated protein or not produced, or there's a splice site change. There are variants of undetermined significance, and those are often the bane of our existence. There are likely benign, and there are benign variants. Further talk about types of variants, it's important to know that there are missense variants, in which a change in one DNA base pair results in the substitution of one amino acid for another. There are also silent variant changes in the DNA. And in this case, there's no change in the amino acid. And these are either benign, or they can be around a splice site, in which case they can lead to differential splice site, either producing a splice site or skipping a splice site. Nonsense variants are a change in one DNA base pair that signals the cell to stop building a protein too early. And so this will truncate a protein or lead to nonsense-mediated RNA decay. An insertion changes the number of DNA bases. A deletion changes the number of DNA bases. And a duplication is a piece of DNA that is copied one or more times. And a duplication can be as small as a single nucleotide or as large as more than the entire gene. Importantly, if a deletion, an insertion, or a duplication alters the reading frame of the gene, This is called a frameshift variant, and it often leads to early truncation of the RNA that's produced. Most genetic conditions present with a phenotypic spectrum. So it's important to understand genetic heterogeneity, in which variants in one gene can cause similar phenotypes, and the term phenotypic pleiotropy, in which variants of a single gene can cause different phenotypes. As an example, on the top, you can see sort of a classic genotype-phenotype concordance in myotonic dystrophy. So changes in DMPK always lead to myotonic dystrophy. In terms of genetic heterogeneity leading to a single phenotype, you can look at the example here of multiple genes, RYR1, MYH7, ACTA1, and Titin, can lead to a central core myopathy histologic type, which also leads to a common phenotype. On the other hand, you can have a single genotype, which leads to phenotypic pleiotropy. An example of that would be RYR1, which can lead to multiple different phenotypes. In terms of genetic testing, it is now pretty well understood that single gene testing does not have a high yield. And so either panel testing or exome sequencing seems to be the most reasonable route to go. In 2015, the Emory Genetics Lab personnel published that panel testing was superior to exome sequencing for the limb-girdle muscular dystrophies. And the advantages of a panel include that they can sometimes see portions of genes that are not seen in exomes, and they can also be enriched so that we can see if there are common intronic variants that are pathogenic, and they can be included in a panel and would not be seen in an exome. Let's just walk through a couple of illustrative cases that will kind of talk through how we deal with genetic testing results in the limb-girdle muscular dystrophies. This is a 38-year-old gentleman who was a former exceptional athlete. He actually was the state champion in his sport in high school, and he developed proximal weakness of his legs at around age 35. His CK always is in that 4,000 to 6,000 range, and you get this genetic testing report. Well, this genetic testing report looks fairly straightforward because at the top you'll see that he has homozygous pathogenic variants in ANO5, and that would lead you to think that he has LGMD2L. And that most likely is what he does have. But the question is, do you have to deal with these other variants of undetermined significance that are also in this report? For me, in general, I'll look at these, and the bottom four are all autosomal recessively inherited. And therefore, even if these were pathogenic variants, that would only lead to carrier status for each of these disorders, and therefore they would not influence disease. However, BIN1 is dominantly inherited. And so then the question is, does this variant of undetermined significance have features that would suggest pathogenicity? And we can go to the report and we can look through that. So in this report, you can see that anything that's underlined in red suggests that it is less likely that this variant is pathogenic, and anything that is in purple underlined makes it more likely. So as we walk through this, we realize that this variant is weakly conserved, which makes it less likely to be pathogenic. It causes a small physicochemical difference between the two amino acids that are produced, which makes it less likely. This variant's present in population databases and at a level that's higher than you would expect for a dominant disorder. And this has never been reported in individuals with BIN1 disease. So all of those make you think this variant is not likely to be pathogenic. The next information is the in silico programs that show that 3 out of 3 in silico programs suggest that this is benign. So all of that information underlined in red suggests that BIN1, this variant in BIN1, is not pathogenic. The only thing that leads you to think that it might be is that the effect of this sequence change on RNA splicing suggests that this variant may create or strengthen a splice site. So once you've looked at the genetics, you do have to go back and say, does the phenotype fit? And in BIN1, you can look at the following. The age of onset is usually 0 to 8 years, and this gentleman was an exceptional athlete until he was in his 30s. And then again, the CK level usually is normal and really never is above 1,000, and therefore the CK level doesn't fit. So I think we can throw out BIN1 and the rest of those variants, and this gentleman does have LGMD2L, or a noctaminal. Well, let's go to another case. So this is a young lady who's 18, and she's had progressively worsening weakness since about the age of 4. She does use a wheelchair for long distances, and her CK is, again, consistently in that sort of 6,000 to 10,000 range. And if you look at the genetic testing, there are a lot of variants of undetermined significance. At the top here, you'll see that there are 2 SGCA, or alpha-sarcoglycan variants. One is known to be pathogenic, but the second one is a variant of undetermined significance. So how do we deal with this? So if you're fortunate enough to have a neuromuscular genetic counselor, jokingly, you could just chirp it to them, and often they'll give you the answer. However, for the remaining 95% of us, that's not going to happen. So let's kind of walk through how you can think through this more complicated report and see if we can figure out how that works, how we can get to an answer. So just as in that first case, if you have a variant of undetermined significance in a gene that's autosomal recessive, at most, that would make them a carrier for that disorder, and therefore we can exclude 2 of these. Next, at the bottom, you have variants in SYNE2 and in Titin. And those are huge genes, and they're very difficult to document as being responsible for disease. And the other is you have to ask yourself, does the phenotype fit? And in these cases, really, to be normal until age 35 and then develop disease doesn't fit well with those diagnoses. But then we're left with RYR1. This is a dominantly inherited disorder. And our Italian colleagues in 2015 published that they looked at all of their patients who had a limb-girdle muscular dystrophy phenotype, and they did genetic testing. And when they did that, if they didn't find an answer with their routine genetic testing, they then expanded their testing. And when they did so, the most common thing they did find were RYR1 mutations or pathogenic variants. But in RYR1, you have to ask yourself the question, does the CK level fit with this case for this young lady? And so in this young lady, her CK levels are always 6,000 to 10,000. And the CK level in RYR1 disorders is generally normal to minimally elevated unless the patient has rhabdomyolysis. But even then, it'll come back to normal. So in this case, I think we can exclude RYR1 also. But then we're left, once again, with a variant of undetermined significance in SGCA, in addition to the pathogenic variant. So how do we clarify this? So sometimes, again, you can go to the report, and this will help you out. So this is the report. And if we start looking through it, you can see that there is a change that occurs just before the start of exon 7. And that makes you think that there could be involvement of a splice site. It notes that this variant has not been seen as a variant in the general population. And then it does say that this variant by in silico, so computer programs, has the likelihood to disrupt a consensus splice site and is of the type that could cause disease. So that makes it much more likely. So then where do we go with evaluation? In this case, we wanted to make sure that these two changes were on separate alleles and not on the same chromosome. So not in tandem, but they were in trans, not cis. And we tested the parents and found that mom had one copy and dad had another copy. So then you can do a functional analysis, such as a muscle biopsy, to look for protein production. And if there's decreased alpha-sarcoglycan produced, then that would suggest that these two variants in conjunction are pathogenic and causing this young lady's disease. And that is what we did. So on the left panel, from top to bottom, you can see a normal control. And on the right panel, you can see that there is decreased staining in all four of the sarcoglycans. And that's not uncommon when there's a pathogenic variant in one of the sarcoglycans, as in this case, alpha-sarcoglycan, that all of the sarcoglycans in the tetrameric complex at the membrane are affected. Another route you could go is you could do RNA sequencing. And it's important to know that some of the genetic testing companies are now starting to do RNA sequencing to help you to determine whether or not variants of undetermined significance are pathogenic or are not pathogenic. Additionally, you can also send a portion of a muscle sample or of blood to a basic science colleague around the country that works in whatever gene, and in this case, the sarcoglycans, that your variant of undetermined significance is. And in this case, another new opportunity for you is that there is a research consortium called the GRASP LGMD, which consists of 11 sites in the United States and 2 in Europe. And they're spread in this country across from the East Coast to the West Coast. And you should be able to find somewhere close by that you could refer your patient or send a sample for further evaluation. So variants of undetermined significance are of incredible importance in genetic disease because most clinical trials require a definitive diagnosis in genetic diseases now. And ultimately, gene-based therapies do require that patients have a definitive diagnosis. At this current time, our treatment of the limb-girdle muscular dystrophies is mostly supportive. And so we have physical and occupational therapy. We have cardiology support for cardiomyopathies. We have pulmonary support for respiratory insufficiency. We have psychosocial support, but we really do not have any treatments that have been shown to modify progression of disease in limb-girdle muscular dystrophies. So, why are variants of undetermined significance so important, and why is it important to make a diagnosis? And the answer is, if you can make a diagnosis, then you can have a definitive diagnosis and end the patient's diagnostic journey. You can determine whether or not their LGMD subtype has other organ system involvement. You can provide prognosis as to progression of disease. Some are mild and will have ambulation throughout life, and others can lead to wheelchair use in the single digits or teens and early cardiorespiratory failure. It'll allow patients to make informed decisions related to family planning, and we've had a number of patients in wheelchairs that are autosomal recessive LGMDs that have had children. And it'll also inform about the possibility of participation in clinical trials. And it's important to know that gene transfer programs currently are in phase 2 clinical trials with human systemic delivery of vector. I'm going to leave you with this statement, which is, in 2020, the diagnostic process for the limb-girdle muscular dystrophies requires broad genetic testing as the first step once a clinical suspicion is present for genetic muscle disease. So do the genetics first and then help confirm them afterwards. Thank you very much. And now I'd like to introduce our next talk, which will be on preclinical development of gene therapy for the LGMDs. And this will be given to you by Eric Hosgay.
All right, well, thank you, Matt. And now that we have a comprehensive understanding of the limb-girdle muscular dystrophies and really the complexity behind these diseases, we want to focus our attention to the preclinical development of gene therapies for therapeutic interventions for the limb-girdle muscular dystrophies. Now, the first thing I want to do is take a step back to something that Matt spoke to earlier, and that is the importance of the dystrophin-associated protein complex and its role within the muscle, and specifically within limb-girdle. So as we saw, and as we can see in this diagram, the dystrophin-associated protein complex is this large multimeric protein complex that spans the muscle membrane and connects the intracellular actin cytoskeleton with the extracellular matrix. And this ultimately results in the stabilization of the plasma membrane in both striated skeletal muscle as well as cardiac muscle. And so as we saw, the limb-girdle muscular dystrophies result from these loss of function mutations in a variety of different genes encoding a number of different proteins involved in structure and function of the muscle. And that ultimately results in destabilization of the plasma membrane, leading to the clinical phenotypes that we saw in the previous section. So now as we transition into looking at the programs that we focus on, we'll start out by looking at the sarcoglycan proteins, which as you can see in the diagram are these structural proteins that are anchored within the sarcolemma. Now the sarcoglycans ultimately function to help prevent muscle damage during muscle contraction. Furthermore, then, when we look at dysferlin and anoctamin 5, these two proteins have more of a functional role and really support muscle membrane repair following damage. And then finally, we have calpain, which is an enzyme located intracellularly, and this is really involved in, it's an enzyme involved in waste removal as well as sarcomere remodeling, the sarcomere being the main contractile apparatus for the muscle. So before we get into the specifics of our gene therapies, I just want to highlight two major distinctions of gene therapy. Now, the first that we're going to talk about and that we focus on with our programs is called in vivo gene therapy. So this involves taking a therapeutic transgene, placing it inside a viral vector, and then delivering that vector into patients. Now, the other type of gene therapy is called ex vivo gene therapy. And this ultimately results from removing cells from a patient, using a viral vector to manipulate those cells in some way, and then reintroducing these genetically modified cells back into the patient to result in a therapeutic benefit. However, again, the focus of our programs is strictly with in vivo gene therapy. Now, the first two steps resulting from in vivo gene therapy, and something that I want to highlight here, is really the distinction between transduction and expression. So the first step following the delivery of our gene therapy is transduction, and this involves the delivery of our transgene DNA into the cell. So taking that therapeutic piece of DNA that we have delivered to our viral vector and ultimately getting that into our target tissue, where ultimately the transgene DNA is maintained as a double-stranded episome within the nucleus. Now, the second step following transduction is expression. And this is really the production of our transgene protein and can be really depend on several different factors, including the effectiveness of the promoter, which we'll talk about in a minute, as well as the stability of this double-stranded episome and ultimately the stability of the protein that is produced. So this slide illustrates the three essential components of our gene therapy development. And we'll go through each of these individually, but just to highlight them as a whole, the first is the viral vector, which, as we just discussed, is the delivery vehicle for our transgene DNA that results in this tissue targeting, ideally with low immunogenicity. Now, the second component is the promoter, which is a regulatory sequence that ultimately is the main determinant for driving expression, this selective gene expression of our transgene. And then finally, last but not least, is certainly the transgene, which is the important determinant of the functional impact of our therapy. So looking for the correct localization of our protein, as well as the restoration of function. So when we talk about the translational development of these gene therapies, preclinically or clinically, as you'll see, we follow a very systematic and stepwise approach. And again, we'll go through each of these individually, but just summarize, the first question that we ask is, are we able to safely deliver our viral vector carrying the transgene to our target cells with minimal immune response, as well as minimal impact to tissue pathology? Now, the two things that we just talked about on the previous slides, the first two steps of our gene therapy is transduction, or getting the vector delivering the transgene DNA into the muscle, and then expression, which is dictated by the promoter, allowing for sufficient expression of our protein in the muscle. And then finally, we have a number of ways to assess is the protein that we're producing from the transgene functioning as it should, localizing in the correct place, and functioning the way it does in healthy muscle. So again, as I mentioned, we want to pick apart each of these components individually, beginning with our viral vector. Now, in all of our gene therapy programs, we utilize adeno-associated virus, which is a common vector that's used in a number of different ongoing and previously studied clinical trials. And just to highlight a few of the attributes of AAV, as a viral vector, it has ability to target a wide range of tissues. And our recombinant AAVs used in gene therapy are designed to be replication deficient. Now, furthermore, AAV is not known to result in any human pathology, and we generally see weak innate immune responses along with lower levels of pre-existing immunity. Now, there are a variety of different AAV serotypes, all with varying tropisms for different tissue targets. Now, this just shows the phylogenetic relationship of all the different AAV serotypes that exist. And of note, in our clinical trials, in our gene therapy programs, we utilize AAV RH74, which is actually isolated from a non-human primate. And so when we look at the phylogenetic relationship, which you can see spans these different clades based on the VP1 capsid protein sequences of AAV, AAV RH74 is most similar to AAV8. So now I want to go through a few of the characteristics of AAV RH74, beginning with some in vivo studies that we use to look at the broad distribution to a number of different muscle types with RH74, including striated limb skeletal muscle, the diaphragm, as well as cardiac muscle. Now, no toxicity has been observed in preclinical studies in either primates or mice at upwards of 3 times our clinical doses. And then, as I mentioned, clinically, we have seen relatively low pre-existing immunogenicity in humans with AAV RH74. And something that I want to point out is that this is currently being studied in gene transfer clinical trials, not only for a number of different subtypes of LGMD, which we'll talk about today, but also for Duchenne muscular dystrophy. So our platform approach really has shared design principles across these different programs. Okay, so our next component is the promoter, which again drives selective gene expression. So the way these promoters are engineered is by taking certain regulatory sequences of endogenous promoters, and we can actually combine those with different enhancer elements where these enhancers and promoters work synergistically to drive our transgene expression. And ultimately, this is really regulated by the ability of endogenous transcription factors to bind to these enhancer and promoter sequences, again, to drive expression, first transcription, and then ultimately translation of our transgene into therapeutic protein. Now, 2 promoters that we utilize within our LGMD gene therapy programs are both muscle specific. The first of which that we're going to talk about is the MHCK7 promoter. So you can see in the structure of the MHCK7 promoter shown here that this involves regulatory elements of the muscle creatine kinase promoter combined with enhancer elements from that same muscle creatine kinase sequence. Now, the distinguishing factor for MHCK7 is we have an added alpha myosin heavy chain enhancer element And so that really allows or confers this high-level cardiac muscle-specific activity to allow for not only skeletal muscle expression, but cardiac muscle expression as well. Now, the second promoter that we want to discuss is the TMCK promoter. Now, this is, again, a modified version of the muscle creatine kinase promoter. And as you can see in the sequence here, it involves regulatory elements from that same muscle creatine kinase promoter, along with a ligation of a triple tandem enhancer element from a modified enhancer element from muscle creatine kinase. And this really results in robust expression in skeletal muscle in the different animal models that we've studied. However, unique to TMCK is that we see limited expression in cardiac muscle. So this becomes very important when talking about the translational development and which promoter is selected for a particular program based on the phenotype that is seen in the disease indication that we're targeting, particularly whether or not there is evidence of cardiac defects or cardiomyopathy within that disease, therefore requiring or not requiring transgene expression in cardiomyocytes. Okay, so the last component of our gene therapy construct is indeed the transgene, which is the important determinant factor of the functional impact of our therapy. And so just to highlight a few of the aspects of the transgene for our LGMD gene therapies, many of the genes that are affected in the different LGMD subtypes are small enough to fit into the packaging capacity of AAV. So AAV has a small packaging capacity of just under 5 kilobases. However, again, due to the nature of the small cDNAs for many of these genes that are affected in LGMD, we are actually able to deliver the full-length genes of many of these proteins, which then result in consequently full-length protein production. Now, the one exception is with our dysferlin program, which dysferlin is slightly bigger than the packaging capacity of AAV. However, we are still able to deliver the full-length transgene, where we have designed a unique dual vector approach where the gene is split into 2 vectors. And when delivered together, this ultimately results in the production of a full-length episome maintained within the nucleus. And again, that results in full-length protein production of the dysferlin transgene protein. So in all cases, we are ultimately achieving full-length protein production of all these different programs. So this slide just summarizes the 6 different programs for limb-girdle muscular dystrophy that I've spoken to that we have under investigation. And again, involves a variety of different proteins, the structural proteins with the sarcoglycans, and then more functional proteins like calpain or dysferlin and anoctamin 5. Now for the remainder of this discussion, I'm going to focus on our preclinical development for SRP-9003 for beta-sarcoglycanopathy or LGMD2E or R4. Now, what I want to do is really walk you through, again, this systematic and stepwise approach that we take to all of our gene therapy developments as we translate from preclinical to clinical. And as I mentioned briefly earlier, due to the platform approach that we have, a lot of these concepts can be applied to not only the specifics of SRP-9003 for LGMD2E, but really apply to all of our limb-girdle gene therapies, as well as microdystrophin for DMD. So we have a series of questions that I spoke to earlier that we want to evaluate in these preclinical settings. And we have a number of different tests and outcomes that we can use to evaluate these questions. And this begins with, again, do we get the DNA inside of our target tissue, in this case, muscle cells? And then furthermore, once we get the DNA inside, is the protein that is produced functioning normally? So is it located at the sarcolemma, and is it performing its proper function? And we have, again, through a variety of different molecular techniques, as well as immunohistochemistry, the ability to visualize that protein production. Now, one thing that we look at following production of protein is oftentimes, as we see clinically, mouse models of LGMD will present with dystrophic pathology in the muscle. So we want to evaluate, does this protein production lead to an improvement in the histopathology of the muscle? And then by improving the overall environment within the muscle, ultimately, does that lead to a functional benefit in these mice, which have been characterized to, again, recapitulate the functional deficits that are seen clinically. So again, here we have our SRP-9003 beta-sarcoglycan construct, where using this platform approach, we have AAV-RH74, the first component of our gene therapy. The second component is our promoter, which again, for this case is MHCK7. And then the third component is the full-length human beta-sarcoglycan cDNA. So now again, I spoke to earlier this systematic and stepwise approach that we can take when performing preclinical development of these gene therapies. And we ask ourselves a number of questions, which I spoke to on the previous slides. And the first question is, are we able to get the vector into our target cells safely? Furthermore, then looking at transduction, are we able to deliver the transgene and detect the transgene within the muscle cells? Following that, does our promoter, that second component of gene therapy, drive transgene expression? And so not only are we able to visualize that expression via Western blot as a total assessment of protein levels, but also using these immunofluorescence and immunohistochemistry techniques, are we correctly localizing the protein? Okay, so then the last thing that we want to evaluate is, are we able to get a functional benefit from this cascade of events that occurs following the delivery of our viral vector, resulting in transduction of the muscle cells, production of protein, and then ultimately correction of these functional deficits. So as we walk through each one of these individually, we'll begin with, again, are we able to safely deliver the viral vector to our targeted muscle cells? So what we're looking at here is a summary of initial preliminary toxicity and safety studies that we performed with SRP-9003 in two different contexts. One being the LGMD mouse model, the beta-sarcoglycan knockout mice, along with healthy C57 Black 6 wild type mice. Now, in both cases, SRP-9003 was delivered systemically through a tail vein injection, and following a certain endpoint time, full necropsies were performed on these mice to remove a variety of different skeletal muscles, the diaphragm, the heart, along with a number of different organs. And what we can see here, beginning with the study in the diseased beta-sarcoglycan knockout mice, that as you can see in the Western blot shown below, we did not see any transgene expression in any off-target tissues, indicating that our muscle-specific promoter was indeed restricting expression solely to muscle. Now, in both cases, analysis of hematoxylin and eosin-stained muscle and organ tissue, when reviewed by a veterinary pathologist, showed no adverse effects on any of these tissues that were examined. So this is preliminary evidence, again, that we are able to indeed safely deliver our viral vector to our targeted cells. Now, the second two steps, which I've already spoken to a number of times, is looking for transduction and expression. So using a qPCR-based assay, we're able to detect vector genome copies in a variety of these different tissues. So the assay contains a primer probe set that is specific for a sequence of vector-specific DNA. And what we can see is, again, the detection of vector genome copies with typically the highest levels in a variety of the different muscles that we are analyzing. Now, furthermore, as I just referenced with the muscle-specific promoter, following the transduction of vector genomes into the muscle, the promoter is indeed, as you can see in the Western blot in the figure on the right, driving transgene expression in these limb skeletal muscles, along with the diaphragm and the heart. So now to go a step beyond just looking at total protein expression via Western blotting, it's critical that we look a little bit deeper within the muscle to again show correct localization. So using these immunofluorescence techniques, and you can see in the image panels on the right, that when we look at a variety of different skeletal muscles, we can actually visualize beta-sarcoglycan protein, not only this widespread expression of the protein, but the correct localization at the sarcolemma, similar to what we see in healthy Black 6 wild type mice. And then we can actually quantify the level of protein expression by looking at the number of positive fibers. And so you can see that quantification to very high levels of beta-sarcoglycan expression in, again, all of these different skeletal muscles as well as the heart. And this last image just shows the visualization of the sarcolemmal localization of beta sarc in those last two muscles, the diaphragm and cardiomyocytes. Now, again, the next sort of event in this cascade resulting from delivery of beta sarcoglycan is looking for improvement in dystrophic pathology. I mentioned that many of these different mouse models for the different limb-girdle muscular dystrophies, and this is the case with the beta sarc knockout mouse model, present with severe dystrophic pathology. And so one of the things we're not showing here, but that we can also assess is hematoxylin and eosin stained muscle, where we can perform quantitative morphometrics to look at the levels of things like central nucleation and fiber size. However, what we're seeing here is the results of a pico-series red stain to assess fibrotic tissue deposition within the different muscles in these different mice. And so if you focus your attention into the middle panel of these images, you can see that this correlates with the severe dystrophic pathology that we see in the muscles of these mice in both the gastroc and the diaphragm muscle, where healthy green muscle fibers or healthy muscle fibers are stained green, and fibrotic or scar tissue is stained pink. So you can see the heavy presence of fibrotic tissue in untreated beta sarc knockout mice, that level of which is reduced following our treatment in both muscles. And we can actually quantify the level of that pink stain, which you can see in the graphs on the right. Again, in both cases, the gastroc and the diaphragm muscle, the levels of collagen deposition being significantly reduced in treated mice. Now, as an indirect correlation to overall muscle pathology, and really speaks to the idea of stabilizing the sarcolemma with the expression and correct localization of beta sarcoglycan, similar to what we see clinically, these LGMD2E mice will present with high levels of serum creatine kinase, an enzyme that is oftentimes leaked from the muscle due to membrane permeability and membrane instability in the disease state. So when we look at those levels in knockout mice, we can see a significant elevation compared to healthy controls. And then the levels of serum CK are significantly reduced following our treatment, speaking to, again, the stabilization of the sarcolemma. Now, as we transition into looking at functional benefits, we are able to transduce muscle, drive high-level expression, localize at the sarcolemma, stabilize the sarcolemma, and improve the muscle environment. So one of the first assessments that we perform to look at functional benefit is one of the things that's seen in these knockout mice is due to the deterioration of the paraspinal muscles, or the equivalent of the shoulder and girdle muscles in the clinical setting, is these mice will oftentimes present with severe kyphoscoliosis of the spine. So using this X-ray cabinet, you can see in the top right figure or image the severe S-shaped curve to the spine of these diseased knockout mice. And this curvature, this kyphoscoliosis, is improved following our treatment, and we can actually measure the level or quantify the level of curvature of the spine by looking at what's called the kyphotic index. And so you can see that score is significantly reduced from healthy wild-type mice in the untreated beta sarc knockout mice, and then that score is improved to wild-type levels following treatment. Now, as an assessment to overall muscle strength, we have the ability in a number of different muscles to look at the force outputs following contractions. And here we're looking at force measurements in the diaphragm muscle. So strips of the diaphragm are subjected to stimulation and then contraction, and we're able to record the force outputs. We're looking at the graph on the left, looking at specific force in these three cohorts. As you would expect based on the severity of the phenotype in these mice, beta sarc knockout mice present with a significantly reduced specific force output compared to healthy controls. And this force output then is significantly improved to wild type levels in the treated knockout mice. And we can really go a step further by subjecting these diaphragm muscles to a repeated series of contractions, which you can see on the right, to look at the overall resistance to fatigue. So shown in blue, the blue line is the treated knockout mice. And you can see that after this rigorous fatigue protocol, diaphragm muscle from treated mice are significantly more resistant to this fatigue protocol compared to untreated controls. Now, as we translate into a more macroscopic assessment of muscle function, one of the things that we can do is look at overall activity of these mice using laser monitoring of activity cage. And so we've shown here a picture of the activity cage on the left, and you can see that this is a network, essentially a cage with a network of lasers. And the idea is that mice are placed in the cage, and anytime a laser beam is broken, a computer program will record that. Now, the unique thing about this is we can look at movement of these mice in the X and Y directions, or essentially ambulation, how much the mouse is moving around the cage. Furthermore, you'll see or notice that there's a series of higher level lasers, which allow us to detect movement in the Z direction. So vertical activity, how many times is the mouse rearing onto their hind limbs? So as we actually look at the data, we can see that in both cases, for both ambulation and vertical activity, again, as you would expect, due to the phenotype, the untreated knockout mice are significantly less active compared to healthy controls. And both activity outcomes are significantly improved following treatment. So this slide just summarizes this approach, this paradigm that we've walked through, beginning with the safe delivery of SRP-9003 to both LGMD2E mice as well as healthy wild-type mice. Furthermore, then we showed that we were able to get transduction of the muscle, detecting vector genomes within the nucleus of these muscle cells. Furthermore, then transduction and the presence of transgene DNA led to, through the use of our promoter, expression at high levels in both skeletal and cardiac muscle. The transgene protein for beta-sarc that is being expressed is correctly localizing at the membrane, and this is resulting in an improvement in the pathology of the muscle, the overall muscle environment. And then again, as we just walked through, ultimately this is leading to a correction of these functional deficits that are present in these knockout mice. So in the last couple minutes, I just want to take a minute to highlight additional key considerations that we assess during our preclinical evaluation of these gene therapies. So everything that I walked through previously was sort of our standard paradigm for looking at the evaluation of these gene therapies. And to highlight three additional key considerations that we can assess, this begins with the evidence of DAPC restoration. So we spoke about the dystrophin-associated protein complex previously, and due to the interplay of all the different components of this complex and how they work together to really stabilize the muscle membrane and allow the muscle to function as it should, oftentimes in a number of these different diseases is when you lose one component of the dystrophin-associated protein complex, other components of the complex are either reduced or completely absent and lost completely with the loss of the specific protein of interest. So in this case, we're again looking at these beta-sarcoglycan knockout mice. And in this immunofluorescence imaging, you can see in both skeletal muscle as well as cardiac muscle that with the absence of beta-sarcoglycan, dystrophin is reduced at the membrane and alpha-sarcoglycan is completely lost. Both of these proteins are then restored at the membrane following treatment with beta-sarcoglycan gene therapy, indicating that the expression of beta-sarcoglycan and the localization within the DAPC at the membrane allows for the reconstitution of other components of the dystrophin-associated protein complex. Now, to extrapolate this or translate it outside of just the beta-sarcoglycan program in LGMD2E, this phenomenon again occurs across multiple different disease indications. So here we're looking at gamma-sarcoglycan knockout mice, our mouse model for LGMD2C. And we see a similar phenomenon where with the loss of gamma-sarcoglycan shown in the middle panel, both alpha-sarcoglycan and beta-sarcoglycan are completely absent at the membrane. Furthermore, then, as we saw in the previous slide, treatment of gamma-sarcoglycan knockout mice with gamma-sarc gene therapy allows for not only the production of gamma-sarcoglycan protein and the expression and localization at the membrane, but it allows for the reconstitution of other sarcoglycan components, in this case, alpha and beta sarcoglycan. So these are two pieces of evidence showing that production of a protein of interest, the missing protein within a specific disease, allows for the reconstitution of other components of the dystrophin-associated protein complex. Now, the second key consideration that we want to assess is everything that was shown previously in the context of our SRP-9003 program involves the treatment of very young mice. So at the very beginning of the disease pathogenesis in these diseased mice. However, as we think about translating this clinically, oftentimes we will be in a situation where we will be treating older, more severely affected muscle. And so in an attempt to evaluate the ability for our gene therapy to be delivered to more severely affected muscle, again, we're going back to the beta sarcoglycan knockout mice. And here we're showing the results of treatment at 6 months of age. So in the presence of severe muscle, high levels of fibrotic tissue deposition, and other components of the tissue remodeling that occurs throughout the disease pathogenesis. And the take-home point here is, again, as you can see in the immunofluorescence staining, that we're able to achieve widespread protein expression in transduced muscle cells that is, again, correctly localizing to the membrane. And furthermore, we're still able to provide a benefit to the overall pathology of the muscle, even when treated at this older age, with the evidence of reduced collagen deposition, as evidenced by the picroserous red stain. Now, again, in an attempt to translate this outside of just the beta sarcoglycan program, here we're looking at the treatment of dysferlin knockout mice, the mouse model of LGMD2B. And once again, when delivered to 6-month-old mice, which present with more severe phenotypes, including the presence of fibrotic tissue deposition and high levels of centronucleation, so these indicators of degeneration and regeneration that is occurring throughout the disease pathogenesis, again, we can see sustained protein expression in the immunofluorescence staining. And taking it one step further, we're actually able to see, using a laser monitoring of a membrane wounding assay, we can see that due to the nature of dysferlin being involved in membrane repair, a functional benefit with improved repair capacity in treated mice, even when delivered to more severely affected muscle. So the last key consideration or key question that we want to ask outside of our standard preclinical development is the ability to demonstrate durability of gene therapy. So again, everything that was shown previously in the context of the SRP-9003 program was following a shorter term endpoint of 24 weeks. Standard endpoints are oftentimes 12 or 24 weeks. However, in a study that we're showing here, we wanted to look at or assess the effects of the gene therapy greater than 24 months post gene transfer. So essentially the entire lifespan of these knockout mice. And again, using immunofluorescence staining, we can see very widespread protein expression following our gene transfer at this long-term time point. Notably, that the beta sarcoglycan protein is still correctly localizing to the sarcolemma in both skeletal and cardiac muscle. And as you can see, we can get virtually no loss of expression in all of these different skeletal muscles, the diaphragm, and the heart compared to a shorter term endpoint. So finally, as another demonstration of durability of this AAV gene therapy platform, again, going to now the dysferlin program in the LGMD2B mice, treatment at more than 15 months post gene transfer via IF immunofluorescence staining as well as Western blotting shows sustained expression of our dysferlin transgene protein in both the TA and the gastroc muscle. So it's another piece of evidence of the durability following long-term endpoints of our gene transfer. So with that being said, I will hand things over to Louise to discuss the clinical development of SRP-9003.
Thank you, Eric. That was a great overview of our preclinical development, which will make this presentation quite simple. I'm going to present the clinical development of 9003, gene therapy for beta sarcoglycanopathy. Now, just to remind you and take you back to Eric's presentation, beta-sarcoglycan, the gene responsible for LGMD2E, is a critical component of the dystrophin-associated protein complex and critical to membrane stability in the fact that it also binds with dystrophin. And this is critical as we think about how we developed our vector system for this program. As previously mentioned, there are three essential components of gene therapy development. The first being the vector. This is our RH74 vector, which is important for tissue targeting. This is what enables our gene therapy to get to muscle, both skeletal muscle and heart in this case. It also has low immunogenicity, meaning that there are a low number of patients in the population that have pre-existing antibodies to the vector. Next is the promoter. The promoter is like the light switch, which turns on the gene in the tissues of interest, in the muscle of interest. We're using the MHCK7 promoter, which turns on the gene to make that protein in muscle, both cardiac and skeletal. And finally, the transgene, which in this case is the beta-sarcoglycan gene, and we are delivering the full-length gene. It's not miniaturized in any way. It's the full-length gene with the wild-type function. Now I'll just go into a little bit more detail on our beta-sarcoglycan construct, which just means the totality of the RH74 vector. Again, this is what allows our gene therapy construct to get to the muscle. It's our little delivery vehicle. Next is the MHCK7 promoter. This is our light switch, which turns on the production of the beta-sarcoglycan protein in skeletal muscle and cardiac muscle, as well as the diaphragm. And finally, the beta-sarcoglycan gene, or cDNA. This is full length, and this is packaged into a self-complementary vector, which enables robust transduction and expression once it gets to the muscle. Now, there are many questions to consider when evaluating therapies, and we'll go through these questions as we transition through the clinical data. So the first key question is, what is the safety and tolerability of the experience with our 9003 clinical study? So next is the transgene inside the muscle cells. We do biopsies at baseline prior to gene therapy and then post-gene therapy in the case of 9003 at 60 days. And the first thing we look for is vector genome copy numbers. And this asks the question of, did the vector get into the nucleus of the DNA? And this tells us how efficient our therapy will be. Next is the desired protein being made. This is done by Western blot. This tells us how much of the total protein is inside the cell. But the critical question is that protein at the cell membrane, and how much is there? For beta-sarcoglycan to function properly, it needs to be integrated into the membrane with the rest of the dystrophin-associated protein complex. And so then we can quantify that in multiple ways by counting the number of beta-sarcoglycan positive fibers, and then also measuring the intensity of the protein signal at the membrane. And finally, is muscle function improved? It's important to get beta-sarcoglycan expressing at the membrane, but is this leading to function? And we have many functional outcomes, with our primary being the North Star Ambulatory Assessment. And we'll go into that in more detail as we get to those results. This is the study design for our LGMD2E study. It was designed for patients between the ages of 4 to 15. This is an open label study, a single site study done at Nationwide Children's with Dr. Mendel as the PI. This is a systemic delivery gene trial with safety and efficacy as the primary outcomes. The first cohort was dosed with a dose of 5 × 10⁻³ vector genomes per kilogram, and 3 patients were enrolled in this study. So as we go through the results, we'll be looking at biopsy results from this cohort as well as function. In this cohort, subjects were put on prednisone 1 mg/kg daily for 30 days. And in the LGMD population, steroids are not a standard of care. So this is additional steroids that patients were not normally exposed to. In the first cohort, for 30 days, and then were tapered. And then for the second cohort, patients were dosed with 2 times 10 to the 14th vector genomes per kilogram, about 4-fold higher. And 3 subjects were enrolled. In this case, subjects were on prednisone at 1 mg per kg daily for 60 days before being tapered. And I'll talk more about that as we progress the results. The initial primary functional outcome is at 1 year, but patients are followed for a total of 3 years for safety and efficacy monitoring. Just a few more details about the trial design. The key inclusion criteria included confirmed beta-sarcoglycan mutations in both alleles. Patients had to be negative for RH74 antibodies and be greater than 40% of normal on the 100-meter walk test. Biopsies were taken at both baseline and at 60 days post-gene therapy, with safety being the primary endpoint, but various secondary endpoints, which included beta-sarcoglycan expression in the biopsies at 60 days, and other endpoints included change in creatine kinase, as well as the various functional endpoints, with NSAD being the primary. These are subject demographics at baseline, and what you can appreciate, again, here we had 2 cohorts with 3 patients each. We had an equal distribution of males and females throughout both cohorts. Again, LGMDs, especially in the case of LGMD2E, affects both males and females equally. In terms of age, we had a broad age range that ranged from the age of 4 all the way to 13. Majority of mutations were in exons 3 or 4, which are known to be lead to a complete absence or severely reduced expression of beta-sarcoglycan with a severe phenotype that includes cardiomyopathy. Our 6th patient with a mutation in exon 1, this was actually a mutation in the very first codon of the gene, so this is predicted to lead to a complete absence as well. There was also a large weight range ranging from 18 to 57 kilograms, which overall in our development has given us exposure to dosing patients that are both older and larger. And finally, creatine kinase levels are also significantly elevated in this population, as you can see in both cohorts, well above the normal range for creatine kinase. First, we'll talk about safety, and we'll do this by cohort. So for cohort 1, 2 subjects had elevated liver enzymes. One of those was designated as an SAE, as this subject had transient increase in bilirubin. Both of these instances occurred when the subjects were being tapered off oral steroids and then returned to normal limits within 30 days following additional steroid treatment. And as I mentioned previously, this led to the protocol being amended to continue the steroids for 60 days before being tapered for the second cohort. In cohort 1, 2 patients also had transient mild nausea within the first week that coincided with steroid dosing, but not liver enzyme elevations. And there were no other clinically significant laboratory findings, so there were no decreases in platelets outside of the normal range or no clinical sequelae associated with complement activation. This is a phase 1 study. These preliminary outcomes definitely need to be confirmed. Now for cohort 2, safety, the majority of the patients had mild to moderate AEs, which resolved. There was one SAE, which was dehydration resulting from vomiting 3 days after infusion, and that resolved very quickly with antiemetics and IV fluids. There was one patient that had mildly elevated GGT, returned to within normal limits while tapering steroids, and there were no other increases after the tapering was concluded. No stopping or discontinuation rules were triggered by any of these AEs, and no other clinically significant laboratory findings in cohort 2. Again, no decreases in platelets outside the normal range and no clinical sequelae associated with complement activation. So next, the next few slides are going to be focused on the muscle biopsies that we took at 60 days. So as you remember, the first question I posed was that we need to know how much of the vector actually got into the cells. So if we compare both cohort 1 at 5 times 10 to the 13th and cohort 2 at 2 times 10 to the 14th, you'll see that in the first cohort, we had 0.6 copies per nucleus. So for every nuclei within the muscle, we had an average of 0.6 copies. Whereas at the higher dose, we saw an increase in this, where we see an average of 4.2 copies per nucleus. Next, we asked how much beta-sarcoglycan protein is made. And remember, this is the wild type copy of the gene, so it's making the wild type protein. And when we looked at the subjects in cohort 1 at our low dose, we see a mean of 36.1% compared to normal. You can see on the right, this is an image of the Western blot, and you can see a dramatic difference between pre and post therapy. So next, we're going to compare the Western blot levels between both cohort 1 and cohort 2. You can see for cohort 1, the mean was 36.1%, but in cohort 2, we saw an increase with a mean of 62.1%. And the range for cohort 2 ranged between 53 and 70% of normal. So next, we looked at immunofluorescence. This is staining for beta-sarcoglycan at the membrane. And as you can see here on the top, we have in our first cohort, baseline levels, which are very low, as opposed to post-treatment levels, where you can see a wide range of expression in our post-dosing. And this is compared to our normal control, which you see on the left. So we quantified this in two ways. We counted the number of fibers and see a mean of 51% versus intensity, which is the amount of beta-sarcoglycan protein at the membrane. And here we see 47% intensity. Next, for cohort 2, we correspondingly see an increase in the amount of expression in these 3 patients for a mean of 72% of beta-sarcoglycan positive fibers, with intensity at 73%. Again, this is the amount of beta-sarcoglycan correctly localized to the membrane compared to normal. So this next slide just summarizes the results from the immunofluorescence staining in both cohort 1, the low dose, and cohort 2 at 2 times 10 to the 14th vector genomes per kilogram. And again, here you see that there was a nice dose response with respect to our second cohort with a mean of 72% beta-sarcoglycan positive fibers and 73% intensity. This is well above what was the threshold for success for this trial, which was greater than or equal to 20% of beta-sarcoglycan expression. So next, we know from the staining that I just showed you, the immunofluorescence staining, that beta-sarcoglycan was expressed at the membrane, but we took it a step further to look at other components of the dystrophin-associated protein complex. So we took muscle sections from biopsies. This is an image from our patient from cohort 1. And we see here as we stain for beta-sarcoglycan in green, we stain for alpha-sarcoglycan in red, and then merge those images. And what you can see by the colocalization, we see yellow, which means that these proteins are in fact sitting in the same protein complex. So next, we looked at creatine kinase levels in both cohorts 1 and 2. Creatine kinase is an enzyme that's leaked into this serum in patients with muscle disease. That includes LGMD upon muscle damage. And so what we did is measured CK levels at baselines, as well as day 90 here is what we're seeing for both cohorts. And what you can appreciate, for every single patient, we see a dramatic decrease in the amount of creatine kinase following gene therapy. So we see a mean for cohort 1 of 83.4%, and for cohort 2, a mean of 89.1% reduction. Next, in terms of functional outcomes, we look at the NSAD, which is an activity scale developed originally for dysferlinopathies, but can be applied to other LGMDs. It incorporates items from the motor function measure test as well as the NSAA. Most of the activities are graded from 0 to 2. So for 0, the individual is unable to achieve that task independently. A score of 1 says that the modified method needs to be used to achieve that goal. And for 2, this is a completely normal activity, normal function for this activity. So the majority of these are ranged from or graded from 0 to 2. There are a few of these functions which are just scored 0 or 1 to get to our total. So these are the NSAD results for the first 3 patients, cohort 1. And what you can see here is that there is a significant increase from baseline in terms of the NSAD. And importantly, this continues over the first year. So 360 days, you can see not only a consistent improvement, but an increase over time. These are the results of the NSAD, but as well as other functional outcome measures across our first 3 patients in cohort 1, our low-dose cohort. And what you can appreciate here is that there's a improvement from baseline in every single functional measure in all of the patients. So we've already shown as NSAD, we see a mean of 13% increase over the year. Whereas in time to rise and 4 stairs up, we see a 24 and 22% increase respectively. And then in the time test, we see 11% and 14% in the 100-meter walk test and 10-meter walk test, respectively. So the patients in cohort 1 will continue to be followed for their function, and the patients in cohort 2, the high dose, are continuing to be followed, but it's still early in terms of looking at their function. So just to summarize the results from cohort 1 in terms of safety, we did have 2 subjects with elevated liver enzymes. One was an SAE, but these resolved with increased steroids, and that led us to modifying our protocol for cohort 2, in which we had limited elevated liver enzymes. 2 patients had transient nausea within the first week, but this did not coincide with other laboratory findings. In terms of our biopsies, we saw a mean of greater than 10 to the 4th vector copies per microgram of DNA within the muscle biopsies. This led to 36.1% beta-sarcoglycan expression by Western blot. And when we looked at immunofluorescence, 51% mean beta-sarcoglycan positive fibers with 47% intensity compared to normal. And finally, we saw an improvement in muscle function over the course of a year with a mean of 13.2% improvement on NSAD from baseline. And to summarize cohort 2 results, in terms of safety, the majority of patients had mild to moderate AEs, which included nausea and vomiting. There was one SAE that was observed, that was dehydration resulting from vomiting 3 days after infusion. This resolved very quickly with antiemetics and IV fluids. One patient had mildly elevated GGT, which there was no intervention and resolved during the tapering period. No stopping or discontinuation rules were triggered. In terms of the biopsies, there was a mean of greater than 10 to the 5th copies per microgram of DNA in the post-gene therapy biopsies, which led to 62.1% beta-sarcoglycan protein by Western blot, 72% beta-sarcoglycan positive fibers with 73% intensity correctly localized to the membrane. In terms of function, it's very early on in cohort 2, and we will follow up with results in the future. So our next steps, as we mentioned, cohort 2 has been dosed. We see expression in the range of 72% in terms of muscle fibers with this 4-fold increase, and we'll be following patients for function. Based on these results, taking into account both safety and efficacy, we will select the final dose for a registration trial from these 2 doses that are studied. And we'll be engaging with global regulatory agencies to discuss our pivotal trial designs. So next, I'd like to thank you very much for your attention, and we're going to transition to a question and answer session. Thank you very much.
Thank you, everyone. You can submit your questions by pressing the box, the Q&A link box. You can submit live questions there. And then we kindly ask that attendees use their cell phone camera to access the post-meeting survey by hovering over the QR code shown here on the slide. Should you encounter any technical issues, please note that Sarepta will send out an access to this survey, a link to this survey after the conclusion of the symposium as well if you have difficulties with the QR code. All right. And with that, I believe we will start with our first question. And I have Dr. Wicklund and Dr. Posguy here with me as well. And Eric, this first question is for you. Regarding the IHC images of muscle fibers, the fibers appear to be of varying sizes. Does the size of these fibers have that much variance, or has it been adjusted for individual images?
Yeah, thanks, Louise. So one thing that we can do to aid in our histological assessment of these mice is perform hematoxylin and eosin staining on muscle and perform quantitative morphometrics. So all of the images that we're showing have the same scale, are the same objective. However, when we quantify fiber size, what we'll see is in diseased knockout mice, the distribution of overall fiber size widens and expands. And therefore, this results in a smaller average fiber size in untreated disease knockout mice. However, performing the same assessment on the treated mice, we do see a normalization of fiber distribution similar to what we see in wild type mice.
Great, thank you. And I believe our next question is for Dr. Wicklund. Can you comment on the GRASP study?
Sure, it looks like the question got truncated, but yeah, so the GRASP consortium is set up. And so, as I said, there are 11 sites here in the US, 2 in Europe, and there are trials that are in different stages of progression in terms of most of them being currently natural history trials. And I think what I'll leave you with is that we're more than willing to have people reach out to us at any of our sites with questions or concerns that you have in terms of diagnosis of your patients, and then where are we going forward in terms of treatment.
Thank you. All right, the next question is with regards to antibodies. I'll take this. So what percentage of patients were showing ineligible levels of antibodies to the AAV used in the study? So just to reiterate, we do know that there's a small percentage of patients in the population that do have antibodies to RH74 in this case, that would preclude inclusion into a study currently. And so when we've looked across the board, we generally see a rate of about 15 to 17% of patients have antibodies, pre-existing antibodies to RH74 currently, and that would preclude inclusion into the study. So those are currently, this is something that we're obviously continuing to monitor. And as we've talked about publicly, we are actively looking at ways through internal research and through partnerships to look at ways to treat patients with pre-existing antibodies by removing them or blocking them. And these are some of the recent announcements that we've discussed as well. All right. So there's one question about an autosomal dominant form of LGMD, LGMD 1D. So I guess maybe, Dr. Wicklund, maybe you could just speak generally about the challenges with the autosomal dominant forms of LGMD and genetic treatments.
Sure, just briefly, right, so this is the LGMD 1D, or I guess now it's D1. And in terms of treatment, it looks like CRISPR would be an appropriate therapy. And your question is in terms of, are there off-site DNA changes? And I think it's all going to be in terms of how precisely the CRISPR can be applied. I don't know where that is, and I think that this was the extension of the first question. And so I don't know that trial and whether that's ongoing currently at NCH or not. I don't know.
Yeah, just to speak generally about the recessive forms of LGMD, they're very amenable to straight gene replacement strategies or gene transfer strategies where you can deliver a healthy copy of the gene, whereas the autosomal dominant forms, the type 1 forms, are more difficult because it requires a knockdown approach to eliminate a mutant protein. So those are some of the main differences between the type 2 and type 1 forms of LGMD. So it's a good question. All right. I believe that is the last question that we've received. And we seem to be right at time of the symposium. We really hope you enjoyed the symposium, and we're happy to take questions. You can email us questions as well. Please take the time to answer the survey, because it will help us for future symposiums and know the types of information and questions that you're looking for us to answer. So we very much appreciate your time for joining us virtually today. We've enjoyed it, and we hope you did as well. So thank you very much.